So again, good afternoon to everyone. So let's have a recap of what we have discussed last time. It's very important to recall because eventually we have to consider the topics that we have discussed last time, and you need to, kasi we have the theory of learning that retention. After our discussion, probably with the theory is only 60% that you may absorb. So there must be a continuity of learning. Even though you may have your break, you can search the related topics in some of the web sources. So manage it, manage it to continue reading, to explore also. Your professor may not be updated, and as I'm opening this up to all of you, that I may also learn from you as well. Okay. So let us continue. Now, with our discussion, let's have a review of what we discussed last time. We have discussed actually the route of administration and its effects. So the route of administration, specifically, we have discussed enteral and the parenteral route of administration, and we have already identified the basic concepts of what is the relationship between the maximum concentration and the maximum time. So the more that it may have a direct access to the blood, specifically to the plasma, the more that it may reach a fast pace of maximum concentration. So that's one that is really important. So that's why it was reiterated here that the intravenous and the intraosseous, which is obviously the route of administration that may have a direct administration and direct access to the blood, and specifically with the plasma, may specifically introduce an immediate maximum concentration and maximum time of its effect, compared to the transdermal, which may vary accordingly because it may pass through the different levels of the skin, subcutaneous tissues, the from the to the blood vessel, then intravascular before it will reach the plasma. And considering also the oral or ingestion, so it will take 30 to 90 minutes, the almost half an hour to 1.5 hours that the drug may take place or may take its effect. So it may reach to the maximum concentration, but on a long period of time of its effect. So that's why we have considered some oral drugs as considered as maintenance drug or supportive drug, because the effect of this drug is longer. It could sustain blood pressure, it could control the blood sugar. So that's why those oral may support that. But if we are considering emergency situations, so we may choose on this hierarchy on which it will facilitate which of the following routes of administration may promote fast effect of the drug, which is considering the maximum concentration and the maximum time. We have also identified that most or all of the oral drugs passes through the liver, most, because the drug will be metabolized by the liver because it will pass the GI or the GUT, then passes through the liver before it will reach to the circulation. And with that concept, the detoxification function of the liver is what we call the first pass effect. So this concept is applied to all oral drugs or those route of administration, which is the ingestion. Now, so as mentioned with the stages of drug movement, most that you have studied in the chemistry, biochemistry, this is somehow related to the some concepts that are related for us to understand how drug takes place, how drug transfer from one area to another, how the drug will be distributed all over the body. So we have the mechanism of absorption. So we have the passive transport. If we say the passive transport, we have considered the term diffusion. If we consider the term diffusion, does this term diffusion refers to absorption from higher to lower concentration or lower concentration to higher concentration? Anyone? If we're considering diffusion, is this referring to the absorption that concerns with higher concentration to lower concentration, or higher concentration to lower concentration? Anyone? If we refer to diffusion, since the concept of drug, yes, Miss Jaila Langkas.
Higher concentration to lower concentration po.
Okay. So, thank you so much. That's correct. So, if you still recall the video that you have watched before, di ba we have the presentation of the axis, and the graph that shows that when the drug enters the body, it will reach the maximum concentration, and that is related to time. So once it reaches the maximum concentration, it will lead also to the decreased slope of the graph because the diffusion takes place. Di ba? Higher concentration, then absorb and becomes lower concentration because the excess properties and chemical properties of the drug are already divided. Another concept that we may consider here in when it comes to the diffusion, I have introduced to you about half-life, right? The half-life of the drug usually happens when for example, with the range of time that the drug will be absorbed by the body, the half-life happens that 50% of the drug is already taking its effect and distributed to the body. The other 50% probably could happen with excretion and elimination. So what does it mean? So there could be a possibility that the 50% of the drug is already now distributed to the body, and the other 50% could be excreted to the body. So that's why the concentration goes down, because the other 50% goes out of the body through the mechanism of elimination. So how we will meet again the 100%? We will meet again the 100% to give again the next dose on its appropriate time. Then here comes again that the concentration of the drug increase and meets to the half-life and becomes still 100%. Then again, it goes down with the diffusion because the other 50% will be eliminated by the body and the other 50% will be absorbed by the body. So that's what we call the half-life. So that's why versus it's very important to consider that the point by which we consider the administration of the drug with the right time and the right frequency. If you will not give the drug on the right time, it may affect the half-life of drug. It may affect possibly the potency of the drug, the potency that's referring to the effect. So another is, how about referring to the pinocytosis? So what do you mean by pinocytosis? If we are considering the point that we have the higher concentration to lower concentration because of the what do you call this? Because of the concept wherein the drug enters the body, and reaches the half-life of the drug. So we connect the relationship with the relationship between the maximum concentration and the time. So if we're considering the active transport, usually the active transport happens when the drug reaches the stomach. This usually I can relate this to the stomach. When the drug reaches the stomach, and it will be transported to the GUT or the GI tract, that is what we call active transport. Why? That is considered as active transport because that is the time that it will continue absorption and preparing the drug to lead into distribution. So when we say pinocytosis, I know that this has been introduced to you somehow in human anatomy and physiology, or even in the microbiology. The pinocytosis usually happens in the intestine. So that's why, if you have observed the video that you have watched, the absorption of the drug usually starts its active transport when it is absorbed in the intestine. So now, I will be showing to you again a video. We have already finished about absorption. We will now proceed to what distribution means. So let's watch.
Hi, in this tutorial I'm going to talk about the distribution of drugs within body compartments. In the previous tutorial I said that this video would be on the metabolism of drugs, but I've decided that it's probably best to talk about the distribution of drugs before we move on to metabolism. For the purposes of distribution, we can consider that the body is made up of 4 major compartments, which are really collections of fluid, and numerous minor compartments. These major compartments are the blood, or strictly speaking, the plasma, fat, extracellular fluid, and intracellular fluid. Then there are numerous other minor compartments. These include the cerebrospinal fluid, the peritoneum, synovial fluid in joints, and the fetus in pregnancy.
Okay. If this figure or initial video illustration is showing on the screen, the distribution starts when the drug enters the plasma, and we all know for a fact that the blood has also cells, which, if the plasma is the one that carries the drug, we have the what we call plasma cells. So the properties of the drug will not just only remain within the plasma, because the purpose of having, why do we have in the lungs pleural fluid? Why do we have in the heart pericardial fluid? Why do we have in the brain cerebrospinal fluid? Why do we have in the abdominal cavity peritoneal fluid? Why do we have in the joints synovial fluid? And with the fetus, with the amniotic fluid. These fluids are the ones that carries nutrients to the cells. And somehow, it is just the same as for the blood. The part of the blood that carries the nutrients, specifically with the properties, with the chemical properties of the drug, is through plasma. So similarly, the plasma, if the drug is indicated for the brain, then we expect that the other properties of the drug will be distributed its target organ, and it will be distributed by cerebrospinal fluid. If the target, for example, is problem with joints, usually these are arthritis, these are problems with inflammatory conditions affecting the joints. So if the drug had been carried, for example, oral via plasma, it will pass to the first pass effect of the drug. Then the drug is carried by the plasma. The other properties of the drug will reach to its target extremities or part of the body if the pain reliever will target specifically joint pain that is primarily caused by arthritis. So those are the purpose. Another example is that of fetus. The fetus receive nutrients obviously from the amniotic fluid also. It is not just only the nutrients that are being carried, but also the waste products that are excreted by the body. On that perspective, di ba, we have the concept that if the mother have taken a drug, question arises that, sir, will the drug properties or chemical properties of the drug may also possible to reach the fetus? That could be possible. That's why, let's have a typical example. A mother who is in labor are being monitored its progress if there will be if there will be regular contractions of the abdomen. The regular contractions itself is an indication that there is an increased level of progress when it comes to labor. The more that it contracts, the chances that the baby is ready to be in the extrauterine life. However, since we still have the amniotic fluid and the circulation of the fetus that is dependent with the mother, going back to the concept wherein the drug is carried by the plasma. If the mother took a specific drug, for example, the doctor, since the patient is in pain, the doctor give a narcotic analgesic. And most of the narcotic analgesic may cause or may alter the sleep-wake cycle and alter consciousness of the patient. The patient could be drowsy. If the mother will be drowsy, it may also cause an effect to the fetus. To what extent? That's why it is not advisable for the mother to be given this narcotic analgesic or pain medications because it may not effectively monitor the progress of labor. And somehow, if on the late stage of labor, these narcotic analgesics will be given, if the mother experiences drowsiness, it may also affect the newborn that will experience drowsiness. So that's why when the mother reaches the point of full dilation and the baby had been delivered, observe, the baby is not crying. The baby is not responding because the baby, the newborn in the extrauterine life was also affected with the drug given to the mother that causes also drowsiness. So it may also have a direct effect to the baby. And how is it? Because the fetal circulation is still connected with maternal circulation. So these fluids are the ones that where the drugs will be distributed. Moreover, we have studied in the anatomy and physiology about cell. Cell is divided into two compartments. And what are the two compartments of the cell? What are the two compartments of the cell? The clue is already in the screen. What are the two compartments of the cell? Yeah, I've heard it. Miss Karaig?
Intracellular po and extracellular.
Thank you so much. Intracellular and extracellular. So meaning, with that two compartment, the cell has intracellular and the outside part is considered as the extracellular fluid. And this has also electrolytes. Okay? If you can remember your learning in anatomy and physiology, we have the what we call, even in chemistry we have the what we call anion and cation. Which of the two, cation and anion, considered a positively charged cell or electrolyte?
Cation po.
Cation. Very good, Miss Alangkas. So obviously, the anion is the one referring to negatively charged. So that's why, keep this in mind. If you will be studying intravenous fluids, the concept of intracellular and extracellular is very important. In extracellular compartment, meaning outside, ibig sabihin the outside compartment, because we have the intra. The extracellular, the highest cation ion or positively charged electrolyte for extracellular is sodium. Okay? The negatively charged electrolyte that is highest in extracellular is chloride. Again, for extracellular compartment, the highest positively charged or cation electrolyte is sodium. The negatively charged electrolyte in extracellular compartment is chloride. Now, how about intracellular? For intracellular, the highest positively charged electrolyte is potassium. And the highest negatively charged for intracellular or anion is phosphate. Recall. Answer me. What is the highest positively charged or cation for extracellular?
Sodium.
Very good.
Sodium po.
Okay, thank you. What is the highest positively charged or cation in intracellular?
Potassium.
Potassium. What is the highest negatively charged or anion in extracellular?
Chloride.
Chloride. Very good. And how about the highest negatively charged electrolyte in intracellular? Phosphate. Okay. When intravenous fluid comes in, just like a typical situation that you will have hydration or intravenous therapy to your patient. In colloquial, suero. Okay? So we have intravenous fluid. So if there will be an introduction of intravenous fluid, the drug enters primarily in extracellular or intracellular. Again, if a drug or intravenous fluid enters the body, specifically in the blood, which compartment specifically and primarily will enter the drug? Extra or intra? Answer?
Extracellular.
Very good. So outside first before going to the intracellular. Put this in your mind, trivia. That's why if you will notice, most of IV fluids, suero, most of the IV fluids contain sodium and chloride. Check the label. Check the label. Most of the IV fluids has sodium and chloride because the initial part that will receive the chemical property or the one that has been deprived if you are dehydrated with fluids and electrolytes is usually starting with extracellular. So that's why the intracellular is still in the middle because the first part that may be affected is the extracellular. So try to check intravenous fluid stock and preparation. Most have sodium and chloride. Going to a situation of dehydration. Are you aware of orisol? Are you aware of orisol? Familiar kayo with orisol? Students?
Iniinom po pag may diarrhea.
Very good. So somehow for pediatric clients, it's Pedialyte. Yan, mga brand na Pedialyte. Do you know that the component of this orisol is sodium, chloride, and sugar? Which is similar that why with all other electrolytes, why it considers sodium and chloride? Because put it in your mind that the initial compartment of the cell that will be primarily affected and absorb properties of drugs, hydrate the cell, is the extracellular compartment. So that's why if you will be dehydrated, the compartment that will initially be affected is the extracellular. So that's why most of the hydration solutions are composed of sodium and chloride. Sir, why it has sugar? Sugar, calories. Dextrose, calories. So that's why, if you will notice, in most of the intravenous fluid, it has dextrose. The dextrose wherein calories could be considered as the source, because the calories is the one that causes the specific metabolic response to immediately have the sodium and chloride enter the extracellular compartment. So having this concept of intracellular and extracellular, sir, why there is fat? Because that is another compartment by which possibly drugs may take place. Why? Because in the plasma, there could be lipids, right? In the tissues, there could be subcutaneous tissues. That's why if an individual is overweight, if an individual is obese, meaning the mass of tissues is increased rather than the usual. Kaya that's why there are, sabi ko, I even told you, why sir, for drug effect, it will cause a delay to an obese individual. Because there could be instances that the drug that is carried by the plasma may not proceed to these fluids. Possibly, it may proceed to the fats. It may store with the fats, and some of the other fluids who must take place in the effect of the drug and distribute it to the indicated organ will be altered. So that's why it caused a delay. So that's why it may have the idea now that if the person is underweight, if the person is overweight, both of the situations may cause the possibility of delay effect of the drug and distribution of the drug. So let us continue with the video.
Numerous others, but for the purposes of this tutorial, we'll consider these as one single compartment. So if a drug is placed into one of the compartments, we can see how it might move and distribute into other compartments. Often drugs are placed into the blood.
The one that that are being mentioned by the facilitator in the video is if the drug is given intravenous. So that's why if you notice, the drug direct to the blood and plasma. And what happens next?
These are drugs which are given intravenously. So when a drug is placed into a compartment, it often associates with binding molecules. These binding molecules are often proteins such as albumin. This process sequesters the drug within the compartment, effectively increasing that compartment's storage capacity. And there is an equilibrium maintained between the bound drug and the unbound drug. The unbound drug within a compartment is then able to move into a new compartment, and thus an equilibrium is maintained between adjacent compartments.
Sir,
When
medyo
a drug moves into a new compartment, some of that drug is
Yes?
mahina po yung video.
Yung audio. Okay, so I'll try to increase the volume.
sequestered by binding molecules within that new compartment. This process continues until there is a balance between each compartment and a balance between the amount of free drug versus bound drug within each compartment. The balance between each compartment is determined by a number of factors, and this is best represented using an equilibrium constant. If you've ever done much chemistry, then you'll have definitely seen equilibrium constants before. But if you haven't, then all you need to know is that they are a number which shows whether the balance is in the forward direction or in the back direction. I'm not going to discuss equilibrium constants further here, but I am going to talk about the factors that affect whether drugs would prefer to move into one compartment versus another. Thus, I can say that the equilibrium constant is dependent on the permeability of barriers between compartments, the pH within the compartment, the binding capacity within the compartment, and numerous other factors such as the fat solubility of the drug, which is especially important for those moving into the fat compartment.
Okay. Class, di ba, I have mentioned to you about the difference between the fat-soluble and the water-soluble drugs. The fat-soluble drugs, usually, when it will be absorbed, there could be a possibility that it may enter through the fats. Now, when the drug properties reaches the plasma, so these drugs will be distributed through and forth. Kaya the arrows is going through and going forth or back. It goes blood plasma, extracellular, some goes to the intracellular, some goes to the fats, and some push and through with other fluids. So what do we mean by that? This movement could be dependent on permeability of barriers. What do you mean by permeability of barriers? For example, actually, if we're considering barriers, the barriers are the boundaries. So we have the boundary between plasma and extracellular, the boundary between extracellular and fats, intracellular to extracellular, extracellular to intracellular, other fluids to intracellular, intracellular to other fluids. The one that are being considered, if we're considering permeability of the barriers, is considering the status. For example, I have mentioned to you about compartments. The compartments with intra and extracellular. If there will be an excess of the electrolytes, example, in extracellular compartment, if there will be an increase in the sodium, okay, the sodium, if there will be increase in the sodium and that is positively charged, will that promote hypermetabolism or hypometabolism? Again, if there is an excess number of sodium electrolytes, and we are aware that this is a positively charged electrolytes. If there's an excess and increase in the level of sodium, it will cause hypermetabolic response or hypometabolic response. Can I hear it from the students? Is it hypo or hyper? If there will be an excess in sodium level. And try to go back to the concept that sodium is why is it hyper? Because the too much stimulation of positively charged, di ba? The too much stimulation of positively charged electrolyte may cause hyper action, hyper metabolic action. So eventually, if for example in the extracellular there's increased sodium, do you think the breakdown of the chemical properties will break down prematurely because of hypermetabolic response? Yes or no? Because of too much response of the sodium in that compartment, will it cause premature breakdown of the drug property? Yes or no?
Yes po.
Yes. So if there will be premature breakdown already of the property of the drug because of too much sodium, because of too much positively charged, do you think it will delay anymore, or it may lower the level of the drug property that will be distributed to other fluids, or possibly it will be decreasing already the concentration on this level and lesser concentration na ang ma-distribute sa body? Yes or no? Yes or no? Again, my question goes, you have mentioned about in this situation, if the electrolyte is positively charged, it may cause hyper metabolic action of the cells. It will lead to hypermetabolic action of the cells. The chemical properties will be synthesized and break down prematurely. So the amount of the chemical property of the drug will be lesser as expected concentration. So there could be a possibility that either lesser concentration of the drug will be distributed to the other compartment, which is supposedly with the target organ and system, or nothing at all, because there could be a possibility at this time that the drug has been synthesized and the concentration of the drug may not be anymore sufficient to take its effect as indicated. So that's what I am telling you. For example, permeability of barriers. How about anemia? If we are considering anemia, are we considering low volume of blood or high volume of blood?
Low po.
Low volume. Very
Volume.
good.
Volume po.
So do you think the distribution of drug matters also with the volume? Yes or no?
Yes.
Yes. So is there a possibility that if there will be anemia and low volume of blood, the greater chances also of less pacing or less or low pacing of distribution of drug? Yes or no?
Yes.
Yes.
Yes. So
Yes po.
chances that if there will be anemia and low volume of blood that will distribute this drug to the different compartments, that may also the what we call permeability of barriers. Okay? Next po. pH compartment. If we are considering pH, that is represented by ion. Okay? Pag sinabi nating for example, it could be acid or it could be base. Chemistry, go back to chemistry. 'Di ba acid or base? Base is also alkalinic. Now, if for example ba, if these compartments may have high acid level or high pH, for example the level of pH is acidic in this extracellular compartment. Di ba too much acidic also may cause premature breakdown of drug? Yes or no?
Yes.
Yes.
Po.
So just the same as, 'di ba? Just the same as when the drug reaches the stomach, tapos the the hydrochloric acid is increased, nagkakaroon na agad ng premature breakdown. So there could be a possibility, going back to the concept, there could be a possibility that the lesser concentration of drug will be absorbed through the intestine. So just the same as in this situation. If the pH is more alkalinic, there could be a possibility of premature breakdown also of chemical properties and may not distribute to other fluids that are indicated with the drug. So another situation, too much alkalinic. If it is too much alkalinic, it's just the same also that if too much alkalinic of the drug may alter also the distribution of drugs. It's either there will be per acidic premature breakdown. It may break down easily or prematurely. For alkalinic, delay breakdown. So that's now the problem. If there will be a delay breakdown, delay also of the distribution of the drug. So that is referring to the pH. So di ba remember when we discussed the buccal? Can you still remember the buccal, route of administration? Los.
Yes
Yes
po.
sir. Chicks
Yeah.
po.
Yeah. Di ba in the buccal, it may need primarily, it is dependent on the level of pH so that it could be, the drug could be effectively absorbed. Yes or no?
Yes po.
Yes.
Yes, sir.
Kaya that's why if the pH is low, it may not facilitate absorption. What I mean low, if for example the location is between the cheeks and the gums, we have the fluids also there, and if the pH of those fluids that are present in that area are low pH, which is alkalinic, then there could be alkalinic rather in the pH, there could be a possibility that it may delay absorption. If too much acidic naman, there could be a possibility that there will be less amount of drug that will be absorbed by a buccal. So that's why there's only an acceptable pH level that is basically required with buccal. So that's the point of that's the point of requirement for buccal. That's why most of, 'di ba, pag cancer pain, it's not advisable to take oral medication kasi it will pass through pa, pupunta pa sa stomach, intestine, liver. So the patient is already in pain for, remember pag ingestion, di ba, 30 minutes to 90 minutes. So can you imagine that the person who is in cancer pain will tolerate pa ba yung 1.5 hour? No. That's why most of the drugs such as the fentanyl are given buccal because of the chances that it may absorb effectively and may have a fast effect because it may reach eventually directly to the blood and the plasma that will circulate its effect. So yun. So that's why we have also the pH compartment. Now, when we talk about the binding capacity, so what do you mean by the binding capacity? This is the ability wherein the properties of the drug will be accepted by these compartments. So for example, binding capacity. We have administered the drug within the plasma. Pero somehow the patient has hyperlipidemia. What do you mean hyperlipidemia? Lipid. Lipid refers to what? It refers to fats. So in this concern, there will be hyperlipidemia or somehow a term which is increase in the cholesterol level. Do you think it may affect absorption? It may affect binding? The answer is yes, because the fats itself may control or may delay the binding capacity so that the property of the drug will be distributed to other compartments. So again, the distribution could be dependent on permeability of barriers, pH or ion of compartments, and binding capacity. So let us continue.
Now I'm going to talk about the volume of distribution, which, depending on the level of pharmacology you need to know, may or may not be important. The volume of distribution, denoted Vd, is a property of the drug which shows how much drug needs to be within the body to get a certain concentration in the plasma. It is defined as the total amount of drug in the body divided by the concentration of drug in the plasma. I'll give you an example of how it might be used. Say I want to get a plasma concentration of morphine of 3/70ths of a milligram per litre. How much morphine do I have to give a 70 kilogram patient? I know that the volume of distribution of morphine is about 5 litres per kilogram of body weight. And I'm trying to achieve a plasma concentration of 3/70ths of a milligram per litre. Well, by rearranging the above formula, I can see that the dose I need to give, which in this case is the same as the total amount of drug in the body, is the volume of distribution times the desired.
Okay, so probably some of you are reacting already because you already see formulas. So we may not concentrate on this. And we will not focus on this formula because eventually this formula will be taught to you in the skills laboratory. So I will skip this video. But somehow you can still watch this video that are posted in our VLE for you for additional information. Now, we have finished about absorption. Let us now proceed with distribution. Okay? So you have seen specifically in the video on how the drug had been distributed. If you can still remember, our concept with the absorption, di ba the concept with absorption is we start with the route of administration. You think of the route of administration or area of administration. So we will just remember di ba the AAS for absorption. AAS meaning area of administration, which is the route. The other A, okay, area of administration, and the other A, I'm sorry, that's ano pala, ayan, A is across tissues, and letter S is systemic circulation. So that is the period that we considered for absorption. Area of absorption, which is the area of administration. Next, AAS, A, across tissues, and after or across the tissues, it reaches systemic circulation. Once the drug reaches the systemic circulation, which is the plasma, this is the time that the plasma will distribute it to tissues. Pag into tissues, it's distribution. If it is across tissues, that is referring to absorption. Remember that, ha? If it is across tissues, absorption into tissues is referring to distribution. That's why I even mentioned from the video that the drug may enter different compartments. So intercompartment yung distribution. Now, there are factors to consider physiologic factors to consider that distribution may be affected. Example, maybe you are wondering that, sir, with the drugs that the person is taking, how the brain could be protected, because you've mentioned that those drugs are carried by the plasma. So if it is within the circulation, it enters different parts of the body, including the brain. So how the brain is protected? The brain is protected from any foreign body, toxins, or any harmful substances through the what we call BBB. What is BBB? Blood-brain barrier. So ayan na naman, here comes the term barrier. So the barrier is the one that divides the compartment, and the barrier could be a form of protection. So the blood-brain barrier is the one, the barrier or the tissues that protects the brain, wherein if the toxic level of the drug reaches the central nervous system, specifically the brain will still be protected. So that's why the drugs may have limited distribution in the CNS, and usually mga highly lipid-soluble drugs. What do you mean lipid-soluble? Yung mga drugs that are fat-soluble. Sa fat-soluble drugs, it passes through the glial cells. At sila ang nagiging in charge para ma-prevent yung damage into the brain. However, if this may cause the effect to the brain if the blood-brain barrier is damaged. To what extent that the blood-brain barrier will be damaged? Injury, there could be infection, there could be inflammation. So if the blood-brain barrier will be affected and the drug enters the brain, so possibly chances that it may affect distribution of the drug. It may affect specifically the drug that is supposedly be circulated to the brain. So it may have an effect. Next, cardiac output. Go back again to the anatomy and physiology. Okay? I would like to ask all of you, what is the normal cardiac output per minute? How many ml of cardiac output per minute?
5 to 6.
5 to 6 liters.
Very good. 5 to 6 liters. Do you think if less than 5 to 6 liters ang cardiac output, it will affect distribution? Yes or no?
Yes po.
Yes. So what are those? I will ask all of you. What are those situations that the heart will bring, or the heart will eject less volume of blood? What are those situations that the heart will have a decreased ejection of blood to the systemic circulation? Anything in mind? What are those situations? So for example, high blood pressure, hypertension. From the term itself, high pressure, if there will be high pressure in the heart because of the volume of blood is retained in the heart, it will not eject the expected 5 to 6 liters as volume. So will it affect ba? Will it affect ba the distribution of the drug? Answer is yes. If you will recall, when the drug is via ingestion or oral, di ba, GUT. Next is first pass effect with the liver. After the liver, pasok sa vein. Pagkapasok ng vein, pasok si heart. After the heart, pasok sa lungs. After the lungs, goes back again to the heart. Then aorta. So considering the long phase of the circulation, there could be a possibility that any of these organs or parts or anatomical structure will be affected. It may lead to the possibility of decreased cardiac output. So another example, do you think it may affect cardiac output if there will be obstruction of paths to aorta? Do you
Yes
think?
po.
Yes. That's why that is the one that you may see in X-ray. Sa X-ray, pag mayroon kayong nadidinig na results na atheromatous aorta. If we say atheroma, class, inculcate this into your mind. Atheroma is referring to cholesterol. Atheroma is referring to fats. That's why if you will see in an X-ray result, atheromatous aorta, it means that there are fat plaques or deposits that are present in aorta. The next question that I have mentioned to you, will that cause obstruction? The answer is yes. Will that cause less volume of blood to be ejected by the heart? The answer is yes. If there will be less volume of blood that will be ejected, it will affect blood distribution of the drug. The answer is yes. So these are the some concerns that may affect physiologic factor. Letter C is body composition. This is the one that I told you that when a person is obese, too much adipose tissues. So if you will notice in the video, di ba, once the drug is administered via the plasma, here comes the time that it may be distributed to the different compartments. If the person is obese, the higher chance of adipose tissues, the greater chances that the level of fats are also increased. On that note, the problem is that of, di ba sabi ko sa inyo, if there will be increase in the fat level or tissues, it delays also the distribution of drug. So that's why one thing that we need to take into consideration is manage your weight, because eventually the amount of adipose tissues may definitely affect drug distribution. So another is blood supply to target tissues. So for example, if the target organ is the heart, if there is a decreased supply of blood in the heart, do you think it may affect also the distribution of drug to the target organ? The answer is yes. Yeah. So, for example, if the patient, as what I have mentioned, is anemic, so this is related to the circulation. So will that affect the decreased blood supply in the distribution of drug? The answer is yes. Okay. Next, degree of vessel constriction and dilation. Okay. Let's set an example, ha. Why is it that most of those individuals who drink too much alcohol, who drink too much alcohol, experience difficulty of breathing? Why? For sure, you have observed this. There are some individuals who drink too much alcohol and experience difficulty of breathing. Yes, Mr. De Leon.
Hindi po ba yung lungs isa rin sa mga nagsasala po ng toxicity sa katawan?
Yes. So that could be. But eventually, you think of a concern that what is the effect of alcohol? Okay? So the effect of alcohol, if it is increased in the blood, kasi we all know, di ba, na when you drink alcohol, usually you experience voiding eh. 'Di ba? The more frequent that you void, ibig sabihin, your liver is working to remove excess alcohol by excreting it via urine. Sometimes too much alcohol is excreted via the skin. Kaya 'di ba, alam ninyo, nakainom ka, amoy alak ka. Because some of the excess amount of alcohol are being released via skin. O alam nyo rin ang nakainom kasi yung hininga niya amoy alcohol. Why? Because some level of the alcohol are also circulating. And we all know that the level of alcohol that are carried by the plasma circulates also in the lungs. So now, what's the point? What's the point, sir? The point is that of the alcohol, too much alcohol causes vasoconstriction. Vasoconstriction. So, if there is too much alcohol, it causes vasoconstriction. Do you think it may affect the flow of circulation? If there's vasoconstriction, yes. If there's vasoconstriction, do you think it may affect the flow of blood? Yes or no?
Yes.
Okay, if it may affect the flow of blood, we all know that the blood carries oxygen. It may affect ba the level of oxygen?
Yes po.
If it will affect the level of oxygen, so meaning the body is not consuming or is not meeting the required level of oxygen that is supposedly circulating, will that manifest difficulty of breathing?
Yes po.
Yes
And
po.
that's why too much alcohol itself causes difficulty of breathing. Yes, Miss Abilino?
Sir, bakit po pag lasing binibigyan ng B-complex?
B-complex. Actually, this is the first time that I've heard that. Pero I've also witnessed because somehow the B-complex, di ba usually the B-complex acts on blood vessel and nerve. So the B-complex may help the action of the nerve to make the blood vessel dilate. And to make the blood vessel dilate, it will cause the sufficient flow of the blood so that it may not cause the possibility of the insufficiency of oxygen supply through the circulation. Yes, Miss De Frances, Claire?
Bakit po yung iba Sprite po yung iniinom?
Ayan. Parang first time ko din. Actually, ano ba ang Sprite?
Chaser, sir.
Chaser. Okay. Kasi ano po let's put in the context why may chaser. Can you enlighten me? Why may chaser? Di ba nagde-dilute?
Or may aftertaste yung
Yeah, other than with the aftertaste, why you considered it with the chaser? It's because it causes you mix it with this, or you have this for purposes of dilution. Kasi remember class, if there will be too much alcohol, the chances na mas maaga ang tama. Why? Because the higher, parang the gamot din yan. If it is concentrated alcohol that you will drink, the higher concentration, mabilis din yan the higher concentration will increase. The chances your liver will function. Tapos eventually, 'di ba, as it goes on, if you will notice, nagbabago yung consciousness mo, nagda-drowsy ka, nagle-less frequent yung urination mo. Kasi alam niyo po that the too much alcohol also cause or slows the electrical impulse. So pag nag-slow ang electrical impulse, it causes also delay in response. Kaya that's why the higher level of alcohol, the lesser chance that the liver will detoxify, the kidney will have lesser chances to remove the excess amount of alcohol, so that supposedly the liver will have the active participation to detoxify, and the kidney must have higher participation. But what happens is that since slow ang response due to dinidelay niya ang electrical impulse and response of these major organs, there's increase in the alcohol. So what happens now? Nag-i-increase yung alcohol sa blood, nagsi-circulate siya, umaabot sa brain. Pag-abot ngayon sa brain, ang magiging effect of too much alcohol level, it slows down the action of the cerebral cells. Pag nag-decrease ngayon ang action ng cerebral cells, do you think it may alter your consciousness, your awakefulness? The answer is yes. It may delay the response of your cerebral cells. It may alter your wakefulness and somehow leads to drowsiness. So may effect 'yon. Kaya that's why pag nagka-alcohol intoxication yan, pupunta na yan sa point na pag nag-lead na yan sa alcohol intoxication, vasoconstriction na yan. So ibig sabihin, major effect na. Difficulty of breathing, decrease of oxygen, oxygen insufficiency to major organs, tapos decrease na ang urination mo, nagpo-fluid retention ka na, nag-i-increase ang alcohol level. So naging intoxicate na siya kasi nakaka-affect na sa function ng brain. And the brain is the central function that controls the major organs. Did I answer your questions? So in short, drink moderately. Pero as much as possible, avoid drinking. Kasi at your instance, compared to adult and compared to your response, at your age, you have longer period before kayo tamaan ng alcohol. Why? Kasi at your age, your metabolic response are very active So the more na ang metabolic response ay very active, the greater chances that the level of alcohol will be removed actively also. So, mas tumatagal ka doon sa pacing na hindi ka tinatamaan ng alcohol. But compared to the adult and the aged, tingnan nyo sila yung talagang merong mabilis maapektuhan because of the delay physiologic response of excreting the level of alcohol. Sila yung mabilis tumaas ang level of alcohol sa blood, and the liver may have also delay in the function of removing or detoxifying in the kidney of removing those excess alcohol in blood. So yun. Any other questions? So what is the lesson? The lesson is manage lifestyle but do not engage much in alcohol drinking. Occasionally that could be, but don't make it habitual. Or try to imagine alcohol at the same time cigarette smoking. That's usually a combination. So kung for example, alcohol, cigarette smoke, nicotine. The effect of nicotine is vasoconstriction. So combined, try to imagine the combination between the alcohol and the combination with the nicotine. Joint force to do vasoconstriction. So what happens? What happens? That the chances that higher level of increased alcohol level, chances also that may affect the liver to detoxify. Easy, parang earlier pace that you will experience tama. So yun yung problema. So siguro may magtatanong sa inyo, sir, why we are asked to drink to take coffee? Anyone? Why in situations like increased alcohol level, or if you have the alcohol has already effect on you, why you are advised to drink coffee or to take coffee? Anyone?
Para po ma-replace
Para
po nung
gigisingin ka,
caffeine
sir.
yung ano.
Some of you says, Paulo says para magising. How about Mr.
Opo.
Gong?
Para po ma-replace po nung caffeine yung inihinhibit po ng alcohol na ano. Na patawag yun sir. Basta po yun.
Sige, tignan natin ha. Okay, now. Di ba the effect of alcohol and the smoke or the nicotine is vasoconstriction, right? So di ba pag nag-cause ng vasoconstriction, nagle-less ang volume ng blood na nire-release ng heart. Will you agree with me? Will you agree with me? Okay, yes.
Yes, sir.
Now, so is there a chance also that the vasoconstriction also takes place in the cerebral system? So kung less yung volume ng blood that is released by the cardiac output, less also yung blood na nagre-release papuntang brain. Tapos may vasoconstriction pa because of too much alcohol and nicotine level. So it really affects your conscious, it really affects your wakefulness. So what happens next? So the problem is the brain is deprived from oxygenation due to vasoconstriction. So dapat there must be a compensation. Ang compensation ng body natin is mag-release ng adrenaline. Pag nag-release ng adrenaline yan, the heart will pump. Kaso this is the problem. The too much alcohol also decreases the response of the kidney kasi nga too much alcohol. So dinidelay niya rin yung response ng kidney kasi ini-slow niya yung nephrocytes. So adrenaline. Lasing na rin ang mga kidney cells. So what will be the response ngayon? Si heart hindi rin magre-response. So do you know that the coffee is a cardiac stimulant? Diba? So if it will cause the effect of cardiac stimulation, it will cause the increased force of contraction, it will cause the increased volume of blood, yes or no?
Yes po.
Yes,
If it
sir.
will increase the volume of blood, do you think it will supplement the needed blood of the brain?
Yes po.
Yes po.
If it will supplement the needed blood going to the brain, then you will, sabi nga ni Mr. Nicolay Alvarez, pampagising. Correct. It goes back to your conscious situation because you have already the sufficient blood and oxygenation by which your cerebral cells will make you alert. So it goes back to your consciousness. So nawawala yung tama because because of the normal circulation that goes with the brain. So yun. So next po. So other than with the degree of vasoconstriction, degree to which the drug binds to plasma proteins such as albumin. Okay. Alam niyo po class, whenever there is a binding between the protein and the albumin, we all know that the protein Di ba the protein is very important for what? Kasi supposedly this protein is responsible for the tissue, di ba? Tissue repair. So supposedly the protein in the digestion will be turned into the amino acids, which is the building blocks of tissues. Ngayon, if there is lacking of protein in the plasma, there's also a chance that it will affect the binding of the drug. So sabi ko, what is the binding that I'm referring to? The drug will not bind to intracellular, the drug will not bind to extracellular, the drug will not bind to the other compartments. Okay, so before I proceed with the next slide, any question? Any question? Class?
None
Ay,
po.
okay, none. So one thing that you've learned from this slide, you may now have the confidence to give strict health education for those who are drinking, for those who are smoking too much, because this may alter, lalo na for those who are hypertensive, if they will continue alcohol drinking, if they will continue smoking, it may the drug that they are taking, even a maintenance drug, may not have its desired effect. It may not reach its therapeutic level because of this effect as mentioned with the constriction. Okay, so I will now proceed to the next slide. The next is, if we have the distribution, we will now proceed with what? Metabolism. And here comes that the liver will take into action.
Welcome to the fourth handwritten tutorial on pharmacokinetics. In this tutorial, I'm going to talk about drug metabolism. Drug metabolism often takes place in the liver, but metabolism can take place elsewhere, such as in the lungs or the gut. The fact that most drugs get metabolized by the liver is very important for pharmacokinetics, because
Okay, I just want to emphasize that statement. Di ba, we have mentioned that the drugs can be metabolized by a liver, the drugs can be metabolized by the GUT, the drugs can be metabolized by the lungs. Di ba, remember the video of the absorption? Di ba, once the drug is given via inhalation sa respiratory, di ba, respiratory pupunta na ulit sa heart, pupunta na sa circulation. May first pass effect ba sa inhalation? Di ba wala? So that's why the lungs itself is the one that metabolize. Yung function ni liver, yan yung tanong nyo, di ba, before, na, sir, paano po pag hindi dumaan sa oral? Usually you mentioned that the liver is the one that detoxifies. Paano na po pag if it is administered to other routes of administration? So that answers now that when it is via the inhalation, the lungs itself is the one already metabolizes it. If for example, if the drug is given via the GUT, okay, the GUT direct hindi papass through the stomach. Yung example na na-mention natin is yung mga rectal suppository. The GUT is the one kasi dadirect na siya sa dadirect na siya sa circulation kasi yung intestine has already the blood vessels and going to the plasma. So hindi na magme-metabolize si liver, si mismong intestine na sa GUT na mismo nag-undergo ng metabolism other than the liver. But most of the oral drugs are metabolized by the liver through the first pass effect.
drugs given orally may be metabolized by the liver before they reach the systemic circulation. This phenomenon is known as first-pass metabolism. Sometimes first-pass metabolism is so dramatic that it necessitates giving a drug intravenously, as giving it orally would lead to significantly less active drug in the systemic circulation. Morphine is an example of this, which is why it is so often given intravenously rather than orally. However, in this tutorial, I'm going to talk more about the biochemistry of drug metabolism, in particular, the actions of cytochrome P450 enzymes, which are often abbreviated CYP. These cytochrome P450 enzymes are abundant in the liver and different types metabolize different drugs. For example, CYP1A2 metabolizes caffeine, whereas CYP2E1 metabolizes alcohol.
Ayan. So, 'di ba? Ayan na. 'Di ba sabi natin, can you imagine yung liver may kanya-kanyang cytochrome. So si cytochrome P450 is responsible for the metabolism of the drug. Iba pa, there's a different cytochrome that metabolizes alcohol. There's a different cytochrome that metabolizes fats. So that's why the cytochrome that is present in the liver is very important for metabolism. So the drug metabolism, the cytochrome P450 is the one responsible for drug metabolism.
Cytochrome P450 enzymes metabolize drugs through a variety of processes. These include oxidation, hydrolysis, and hydroxylation. So let's have a look at how this works, and I'll try and keep the organic chemistry to a minimum. Here is a drug, and this drug has a hydrogen attached to it. This hydrogen is going to be the target of our cytochrome P450 enzyme. Through the process of hydroxylation, the cytochrome P450 enzyme has turned the hydrogen into a hydroxyl group.
Okay. So we are not anymore concentrating on this too complicated presentation. What is important is that of the cytochrome P450 is the one responsible for metabolism of the drug. However, the cytochrome P450, the liver may undergo the three processes: oxidation, hydrolysis, hydroxylation. But the bottom line of these three processes is to process oxygenation. Okay? So oxygenation is very important to process the cytochrome and metabolize the drug. So if ever the liver will be deprived from it, kaya nga sabi ko sa inyo, if the too much alcohol with it, the lesser cytochrome will release, the chances also that the oxygen level of the liver cells will have, the lesser response that it may be. So I may not anymore have this formula be more complicated, but let us now concentrate on how the drug from the liver will be excreted by a kidney.
All this attached to it, namely 3 hydroxyl groups and a carboxylic acid group. This makes the molecule extremely water-soluble or hydrophilic. Thus the drug can be easily filtered and excreted by the kidneys. We call this first part of the process phase 1 metabolism. The second part of the process we call phase 2 metabolism. Let's have a look at an example now. This molecule here is aspirin, or more correctly, acetyl salicylic acid.
Okay. Now, the one that he mentioned about the phases is when the cytochrome P450 is released by the liver, it will undergo these three processes. So with these three processes, it will bind those chemicals, the oxygen and the hydrogen. Now we will not anymore go into details of that. So we have the phase 1 and the phase 2. And with these processes, that's the time that upon the metabolism of the cytochrome P450 having the phase 1 and the phase 2, the excretion already considers the elimination of the excess properties of the drug. So the one being mentioned by the facilitator here is an aspirin. An aspirin is an anticoagulant drug. What do you mean by anticoagulant? Kasi if we say coagulation, the blood becomes a clot, di ba? You try to imagine that the blood becomes a dislodged clot. Do you think if the blood has dislodged clot, it may cause obstruction to blood vessel? Do you
Yes,
think that yes, eventually. So that's why most of the drug being given for those who may have stroke because of the obstruction of the blood clot sa heart, or blood vessels na nag-cause ng heart attack because it is caused by the blood clot. So that's why to prevent the blood clotting again, to obstruct the blood vessels, they are giving the aspirin or the salicylic acid. So we will not anymore concentrate on this because it just mentioned that they have the phase 1, the phase 2 until it proceeds to the excretion. So okay, so next part. Now, when we talk about the metabolism, let's go back again to the action pertaining to the absorption. Absorption is AAS, area of administration or administration site. Another A is across tissues. Letter S is systemic circulation. It stops with systemic circulation. That's absorption. When it comes to distribution, what about with the distribution? With the distribution, it starts with systemic circulation, then into tissues. So we even emphasize, di ba, if it is across tissues, it is referring to the absorption. If it is into tissues, that is referring to distribution. Okay. Now, let us now proceed with metabolism. Usually, there will be an alteration of drug from in the dosage form that are more water soluble. Okay, so if we say water soluble, it could be easily absorbed. Kasi ang maganda lang, the good with the fat soluble, mas nakikerry siya at nakikip niyang intact yung chemical property. Unlike for water soluble, the more na nagta-travel yung drug, the greater chances na nag-change yung chemical property. So can you imagine yung parang pag fat soluble siya, intact siya, na pag nasa plasma siya, protected siya na nagta-travel dun sa plasma until it reaches to the indicated organ. Unlike for water soluble, these are the drugs wherein na pwedeng magkaroon ng mga premature breakdown kasi pwede nga siyang maging soluble or ma-breakdown easily. Usually, the metabolism occurs on the following. We have the liver, the plasma, the kidneys, or the intestinal membranes. Moreover, we have mentioned, di ba, the major organ is the liver. Okay? And this is in coordination with the kidneys. So sabi natin kanina, other drugs that may not have the first pass effect sa liver, we have the lungs, and the other one is the intestine. So metabolism may be affected by genetics. What do you mean by genetics? Genetics, for example, if there are familial history problem with blood. Di ba merong may mga disorders or blood disorders na namamana natin? Example, thalassemia. So probably you will learn this in the in pedia. Ang thalassemia is a genetic disorder. It is inherited. And usually ang thalassemia, ang problem niyan is usually the person anytime will bleed. Kaya that's why yung mga thalassemia anytime yan for blood transfusion, namumblema sa blood transfusion. So ang problema diyan, since it is genetically acquired, kung may problem mismo sa blood, we have mentioned before na merong implication yung level ng blood volume sa distribution ng blood. So it's also the same na ang metabolism ng drug nakadependent sa blood volume. So just the same with with absorption, yung patient's age and physical condition. So kung may pre-existing problem ka ng liver, ng kidney, it may affect metabolism. Patient's age, usually the aged or the old population, the older population, they are the ones being affected with the metabolism. So ito po yung na-mention ko sa inyo na first pass effect. So usually the first pass effect that we're going through, it happens in the liver, and usually pag mga higher doses ng mga gamot, it should pass talaga itong process ng first pass effect ng liver. And as what I have mentioned to you, that it is usually conceptualized na most of oral medications have this first pass effect. So yan yung usually almost complete with this metabolism. Okay, before we proceed to the next slide, any question po? Any question so far? Kaya pa yan? Kaya pa. Okay. Hindi na ba kaya? Kaya pa yan. Kaya pa yan. Okay. Kaya pa yan. Yung iba nagnanad na, yung iba naka-off na, tulog na, inintay na lang yung 7 o'clock. Anyway. So, next po. Next po is other than we have done absorption, distribution, metabolism, metabolism. Now we are leading to elimination.
Hi, this tutorial is the 5th in the Pharmacokinetics series. In this video, we'll be discussing excretion of drugs. Excretion is defined as the irreversible removal of drugs from the body. There are two main ways in which the body excretes drugs. One is via the hepatobiliary system. This is when the liver excretes a drug or a drug metabolite into the bile, which in turn gets excreted with the feces. An example of a drug which is primarily excreted by the antibiotic rifampicin. However,
okay, one important thing that the facilitator mentioned, where does the excretion starts? Still with the liver, di ba? Still with the liver, and usually with the hepatobiliary system. The hepato refers to liver, and the biliary system is the one that secretes bile. Bile is very important because the bile is the one that transports. Yan. So kumbaga sa mga fluids that I have mentioned, ang bile po ay isa sa mga important metabolic substance ng liver that will stimulate the metabolic response of the drug. So next.
Most drugs are primarily excreted by the kidneys. As such, we will focus on this system in this tutorial. In this system of excretion, a drug gets filtered into the nephron of the kidney. If you want more information on the details of this, check out the nephron function tutorial and other kidney tutorials at handwrittentutorials.com. Once the drug is in the nephron, it flows through the nephron into the collecting ducts and ultimately out of the body in the urine. So we can define some values here. First of all, there is a certain concentration of the drug in the plasma. We'll denote this Cp. Secondly, there will be a certain concentration of drug in the urine. We'll denote this Cu.
Okay, now what is clear that after the hepatobiliary system, the drug will be excreted entering the nephron. Okay, entering the nephron and goes with the urine. Okay, so yun lang yung two parts that are necessary for it. So we will not anymore concentrate on the formula, and I will just like to emphasize what this GFR means. Okay, GFR means glomerulofiltrate rate. What do you mean by glomerulofiltrate rate? The glomerulofiltrate rate is the one that may facilitate diuresis. What do you mean by diuresis? The one that will facilitate urination. The one that will facilitate excretion of toxins via urine. So again, the glomerulofiltrate rate is the one that stimulates diuresis, and the diuresis is the one that causes the what we call urination.
People with kidney disease who have a low glomerular filtration rate and also the clearance of that drug. An example of a drug that is actively secreted into the nephron is penicillin.
You know, sabi ng facilitator, the penicillin. Sabi ng penicillin. The penicillin is an antibiotic. Okay? Penicillin is an antibiotic. Usually, ang penicillin are drugs that are prescribed for malaria. Yan, the drugs very strong yan sa mga malaria, very strong yan sa mga situations na it really affects the circulation of the blood.
Now let's talk about something slightly different, orders of kinetics. In the system I've drawn above, the higher the concentration in the plasma, the faster the drug will be excreted. This may
Yun yung sabi ko sa inyo, di ba? The more yung drug ay nagre-reach agad siya sa maximum concentration, mas mabilis din siyang ma-remove out of the body. Kaya nga sabi ko sa inyo, habang parang sa alcohol lang 'yan, di ba? Parang sa alcohol lang 'yan, habang tumataas yung concentration ng alcohol mo, kailangan mabilis din ang response ng body mo para ma-remove. Kaso di ba I even told you that the liver and kidney may slow response to remove the excess alcohol. Kaya I told you somehow the other level of alcohol in excess ay lumalabas sa skin. So by perspiration, yung iba lumalabas via metabolized by the lungs kasi the liver and the kidney may not anymore support kasi nga it delays anymore yung tinatawag nating metabolic response. So in this situation, if you will notice, it may have the same effect pero somehow yung consideration kasi natin, we will not concentrate on this loop kasi masyado ng higher level. Pero one thing lang that we need to understand in this video presentation is after the hepatobiliary, the drug itself goes to the nephron, goes to the urine, we have the glomerulofiltrate rate. The glomerulofiltrate rate is the one that stimulates the uresis and may cause the excretion of the drug. Yun lang naman yung important dyan. Okay, now, it's very important to know that in the elimination, there are major excretion routes. Okay, kidney is the number 1, liver or bile to the feces. Kaya class ganito. Di ba I told you that sometimes there are some drugs that are not capable ang kidney to excrete. So that's why because of the hepatobiliary ang nagme-metabolize, pwedeng si bile pumunta siya at excrete siya yung excess properties of the drug via feces. So one of the example diyan ay yung alin. Anong mga example na nagkakos ng discoloration of the stool? Yung iron-based drug, ferrosulfate. Kaya class, when you are taking ferrosulfate, those na may mga anemic episodes dyan, yung anemia, na pinagtitake ng mga iron-based sa mga buntis, di ba? Sa mga pregnant women, they are asked to have the ferrosulfate kasi when someone is pregnant, ang level ng iron nila ay bumababa in the early trimester of pregnancy. Kaya automatic yan, bibigyan niya ng ferrosulfate. So somehow, ang ferrosulfate o yung iron po ay nagpa-facilitate ng metabolism at excretion via liver. So I told you also it could be metabolized via lungs, so exhalation, breast milk. So ayan, kaya nga sabi natin, pag once you are talking about na kayo po ba ay umiinom ng gamot, kayo po ba ay nagbe-breastfeed. Why? Because one point of excretion is also breast milk. So other than the major excretion, class, there could be either other minor excretion routes. It could be saliva. Okay? Kaya minsan sasabihin niyo, uminom ka ng gamot, ba't parang minalalasahan ako? Hindi because yung pagkaka-take mo ng gamot, nalasahan mo siya. Pero why some instances na sa situation, ba't parang minalalasahan ako? So there are some components of the drug that could be removed via saliva, via tears, and via sweat. So these are minor excretion routes, but major are these areas. So what is route of administration? So minention natin na ang route of administration is the body where the drug absorbed will take place. So we have mentioned parenteral and the enteral route of administration. Actually, pag sinabi natin bioavailability, tandaan po ninyo, di ba meron tayong half-life? Pero once the drug reaches 100% of the effect of the drug, pag 100% na siya, 50% is half-life. Pag nag-reach na siya ng 100%, that is bioavailability. Remember that. 50% half-life, pag nag-reach ng 100%, it's already bioavailability. Okay, so what is onset of action? If you've heard about onset, di ba? What is the onset of the disease? What is the onset of symptoms? Pag sinabi nating onset, it's from the start. Okay? From the start. So, Ang onset of action is referring yung interval ng time na when the drug is administered until nag-start yung effect ng drug. So again, the onset of action is when the drug is administered and at the start of the drug's therapeutic effect. So that is onset of action. Next, ano naman yung peak concentration level? Minention ko sa inyo, di ba, meron tayong tinawag na maximum time at maximum concentration. Yung maximum concentration or blood concentration level na nag-achieve doon sa plasma yung gamot, and di ba doon na bumababa pag nag-reach na sa maximum concentration, ang tawag doon, yung maximum blood concentration is peak concentration level. Okay? Now, sir, nakakalito naman yung number 4 at saka yung number 2. Anong difference ng onset of action sa duration of action? Okay. Di ba ang sabi natin sa onset of action, at the time that the drug ay administered until nag-start yung effect ng drug. Okay? Until nag-start yung effect ng drug. Yun yung onset. Possibly the one that will guide you is begin. From the start that the drug administered and from the start or beginning of the effect of the drug. So nandun pa rin si begin. Pero pag nag-lead na yan into the time na start up to the end. What do you mean end? Nag-reach na talaga yung therapeutic level of drug. That is duration of action. So again, the onset of action is at the start you administer the drug and at the start or beginning na nag-take yung effect of drug. Pag duration of action, at the time yung mismong length, at the time that the drug is administered na at na-complete na siya until the end yung effect ng drug. So mas kompleto yung duration of action. Unlike sa onset, pagkabigay yung simula ng effect. Sa duration of action, pag nagkaroon na definitely ng effect. Okay? So next, ito yung sinabi ko sa inyo, bioavailability. Yung bioavailability, usually yan when the drug reaches the plasma. So ibig sabihin pala, sir, pag ang drug ay binigay mo ng mas malapit sa plasma o direct sa mismong blood and plasma, mas mabilis ma-reach yung 100%. So that's why sabi ko nga sa inyo, 30 to 60% intraosseous, intravenous, mas mabilis yung bioavailability. So pag sinabi nyo gano'n, pag the doctor will say, what do you think is the route of administration that will reach immediately the bioavailability? Sir, it's intraosseous and the intravenous. Why? Because sir, the drug directs already to the effect and the effect to the blood and it's already carried by the plasma. Wow, promoted ka na niyan. Next, where drugs half-life. Okay, so drugs half-life, this is wherein yung concentration, di ba sabi natin kanina, yung maximum concentration. Pag nag-reach na sa maximum concentration, tapos kalahati na niyan will be removed by the body, the half of it will be distributed to the body, it's already drugs half-life. Okay? So ang difference nito, 100% bioavailability, 50% naman is referring to drug half-life. Okay? So let us now proceed to the questions. So let us now evaluate ourselves. These are the questions that have been retrieved from the NCLEX and some local board examinations. Let's start. The nurse administered the drug intravenously which expected, ang bilis ha, nakita agad yung 100%. I think, okay, for a while, I think the first one that I saw is Miss Cipriano. Sige, I'll just show first the choices. Bioavailability, we have half-life, we have duration of action, and we have onset. Miss Cipriano. Miss Cipriano? Nawala na.
A po sir, bioavailability po.
Okay, so let's see if the answer is bioavailability. Correct! Bioavailability. So guided you with a 100% absorption. Next question. The nurse administered the drug on the right time. Miss Avante. I will not show the choices. I know you know the answer. Miss
Half-life po.
Half-life, tingnan natin. So we have half-life, we have bioavailability, we have duration of action, we have onset. Answer? Half-life. Okay. So pwede na pala kayo mag-take ng examination. Next, we have questions. The nurse is aware that manifestation has been observed at the maximum blood concentration. So I think the first one that I saw is Miss Delarmente. We have onset. Oh, sige. I may show first the choices. So answer.
Letter B po din, peak concentration level.
So the answer is correct. Peak concentration level because of the maximum blood concentration. Next question. We have the nurse considers the time interval when drug is administered until therapeutic effect begins. So I think let's call Esquilio. Regolo. Mr. Esquilio, answer. The time interval when administered,
Sir,
time
rinig po ba,
administered
sir?
begins. Answer.
Rinig po ba, sir?
Yeah?
Onset of action.
Onset, because what could be the reference? Because the time started administer until beginning of therapeutic effect. Answer is onset of action. Very good. Next question. Ay, tapos na pala. So I think this will cover the next topic. So we still have 7 minutes for you to have your break. Already the posting already of the examination are already posted, if you will see, but it will start the opening of the quiz of the prelim quiz 1 at 7 o'clock. So we still have 7 minutes. You can have the 7 minutes, maximize the 7 minutes for your break or health break, hydration, then be back at 7 o'clock.